with Dr Caz Hales. Caz was an intensive care nurse for 18 years and has been a nursing academic for 15 years. She is a senior lecturer at the School of Nursing, Midwifery and Health Practice at the Victoria University of Wellington and an honorary research fellow at the Liverpool School of Tropical Medicine. She is co-founder of Bariatric Management Innovation, which supports the development and delivery of safe, appropriate, equitable care and service provision for large patients.
Thank you very much for the invitation today. My name's Caz Hales. I'm a registered nurse and nursing academic at Victoria University in New Zealand. So I've been a registered nurse for about 18 years and I work in the space of obesity care. So my work explores patient and staff factors that impact on the quality of care, patient experiences of people of larger size. I've been an intensive care nurse for 18 years, and for part of that time I've worked for the intensive care flight retrieval team and the hospital medical emergency team. My experiences of the aeromedical transportation and care of plus-size people informs much of my research. So before we start, I just want each and every one of us to take a moment just to think about ourselves. Because all of us will have our own experiences, both personally and professionally, of what it's like to care for plus-size patients, both in care and rehabilitation. Some of us will have multiple perspectives and lived experiences of caring in different sized bodies to the one that we're currently inhabiting today, and that will inform how you approach patient interactions and care practices. It's important to take a moment to consider these perspectives that you have as they act as your conscious biases and your unconscious biases when you engage in education sessions and care practices about supporting effective plus-size patient rehabilitation. So there's lots of different language that we can use to talk about people of larger size. And it's really important to note that there's no universally agreed language to describe an individual living with obesity or plus size that is culturally appropriate or accepted internationally. Similarly, over time, that language, and specifically the use of person-first language, has evolved. Therefore, some of the presentation material used and contained within this presentation actually reflects the language that was used in the original publications, and some of the work presented is close to 10 years old. So over the next 25 minutes, I'm going to present 3 practice-informed research projects that have implications for promoting effective plus-size patient rehabilitation. The first study is an evidence and gap map study, and this highlights the paucity of evidence that focuses on service delivery interventions to improve healthcare outcomes around rehabilitation. The second study is about patient experiences of hospitalisation and mobility, and how these experiences inform service delivery to promote effective rehabilitation. The third study improved healthcare professionals' attitudes and perceptions through simulation, and how simulation of body size transformed health professional understandings and clinical practice. So it's quite a lot to get through in the next little while. Okay, so the first study. So a challenge I've frequently encountered as a registered nurse and academic is locating the robust evidence that specifically guides care practices and service delivery needs for plus-size patients who are not accessing health services for weight management. So when a patient is admitted to hospital, or in my case, ICU, I want to look for the evidence that answers questions like, what is the best equipment to maintain skin integrity, maximize physiological functioning and mobility, and enable rehabilitation? How do I do this whilst minimizing patient and staff harm? How do I prevent avoidable patient harm? How do I prevent falls? How do I prevent injury during moving and handling? So this led me to this project funded by the Health Research Council of New Zealand, which was to establish what evidence is available to support healthcare outcomes. So the aim of the evidence and gap map was to identify and assess the available evidence of healthcare outcomes, healthcare interventions to improve healthcare outcomes for hospitalised patients living with extreme obesity, so plus size patients. The target population was hospitalised adult patients with extreme obesity. And extreme obesity was defined as those individuals with a BMI of 40 and over, weighing 150 kgs or more, which is around 23.5 stone, or having large physical dimensions which affected mobility and made moving and handling difficult. And this is a definition that's commonly used across Australasia within our moving and handling literature and research. So this evidence gap map does specifically focus on hospital services, which is where rehabilitation starts when patients are admitted into hospital. So you can all access this evidence and gap map via the web page that you can see on the slides. So the intervention outcomes framework was developed by an expert advisory team using internationally recognised health system performance indicators that are used around the world to measure the performance of hospitals to deliver patient care. The interventions were specifically related to care considerations important to addressing the needs of plus-size patients. So if you're focusing on rehabilitation, then interventions around assessment tools, equipment, moving and handling, care bundles, and patient mobility are key areas of interest that you would want to look at within this evidence and gap map. So we look at this at the results. On the slide is an image of the evidence and gap map. We reviewed around 65,000 studies related to obesity care interventions. However, only 247 studies were included in the evidence gap map following a full text review. So most of the excluded studies specifically related to bariatric weight loss surgical procedures or interventional techniques that could not be generalised to the wider obesity care or service provisions. Despite this, over half the studies included involved patients who were involved in bariatric surgery as part of the study design. So when we actually look at the gap map, each cell compiles the research at the intersection of a particular intervention and outcomes category. The outcomes are listed across the top in the columns and the interventions along the left-hand margin in the rows. So there are those black columns and rows. The number of studies in each cell is denoted by the size of the data point bubble. As you can see in the image, the large blue bubble represents 158 studies. The small green bubble, just down here, represents only 2 studies. The quality of the research in each cell is denoted by the colour of the data point bubble. So green is high quality research. Light blue is moderate quality, dark blue, low quality, and purple are protocols of studies that are still in progress. So the interactive map allows you to search through the records in a similar way to a search engine using key terms in the filter box. If we write the term rehabilitation into the search box, we retrieved 6 records that mention the phrase in the title and abstract. That's just under 2.4% of the evidence. 4 of those records were single patient case reports about the care provided to a patient during their hospital stay and actually is considered low evidence. The other 2 studies were moderate quality and focused on perioperative procedures. The word rehabilitation was just mentioned in the abstract, but wasn't really the focus of the intervention or the research. So what were the main findings? So our results found that there was little evidence of a holistic patient-centred approach to care of plus-size patients when considering the wider obesity care and service provision needs. Instead, the research contained within the evidence gap map is very targeted and focused at specific points on a patient's healthcare journey and is focused around perioperative care, surgical recovery pathways, airway management, and medical devices. And these mainly fit under the interventions of special care pathways, so in this row here. So the areas of least research are the areas most identified clinical need, especially when considering effective rehabilitation. So for assessment tools, the research here focused on pre-surgical assessment and intubation scoring tools. Again, there was no general focus on the assessment of the holistic care needs of the patient and their rehabilitation needs. There was minimal research on equipment. Only 13 studies focused on equipment that supported patient rehabilitation, functional mobility, and activities of daily living. Unfortunately, this research used clinical audit, single patient case reports, and expert opinion methodologies, so again, low quality research. Moving and handling intervention studies was minimal. Given that preventable patient and staff injury and harm are frequently reported in literature, it was really disappointing to see that there was only 11 studies that specifically focused on interventions to support safe staff-assisted moving and handling. So that's the evidence gap map. And if you've recently completed an intervention study or would like a study to be considered for inclusion into this evidence gap map, then please contact me for consideration and also have a look at the published protocol to see for yourself whether you think that your research should be included in the map. So the next study is about patient experiences of hospitalisation and mobility. So in 2013, I was part of a bariatric working group in the hospital where I worked, and we were given the challenge of set on the brief to review and update the bariatric care policies and pathways, and also to consider the best way of procuring equipment for our patients of larger size. And to do this, it was really important to understand the patient experiences, and they were critical to informing our service initiative. So, patients weighing over 180 kgs that were admitted to One North Island Tertiary Hospital, which was the hospital where I was working, in the previous 6 months were eligible to take part in the study. We chose a weight of 180 kgs specifically because this was the identified need that we needed to understand what resources we needed to put in place to care for this patient population. We used semi-structured interviews to understand the experiences of these patients who had previously been in our hospital, and then we did content analysis. So the table presents a descriptive summary of participant characteristics. So of the 7 patient participants, there were 2 distinct groups of participants with differing levels of wellness, mobility, and functioning levels of activities of daily living. So the first thing that we identified was compromised pre-existing mobility. For all participants, pre-existing mobility, this was their mobility before hospital admission. It was compromised to some extent for all of the participants. However, the 4 participants in Group 1, who were all mobile with well-controlled comorbidities, were all able to independently arrange travel for their hospital admission. This was in comparison to Group 2. Group 2 participants, their extreme obesity severely impeded their mobility and was exacerbated their existing health conditions. Due to their poorly controlled comorbidities, they experienced reduced mobility that accrued over time. Prior to admission, these 3 participants had compromised mobility, whereby they had limitations in independent, purposeful physical movement of their bodies, which required assistance from another person and or mobility equipment aids. So compromised mobility for this group of patients took numerous forms. It varied over time and depended on the state of health the participant was in at that time, and most importantly was dependent on their exacerbations. And these exacerbations of chronic conditions caused participants to become bedbound for periods of time where they were unable to walk unaided and also unable to mobilise. So the next theme was the mobility difficulties during hospitalisation. So during hospitalisation, the physical environment created mobilisation difficulties for all participants, and this was related to geographical location. The geographical location in the ward was important for maintaining or supporting independence with mobility. So the distance between their bed space, the allocation of their bed, and the bathroom facilities limited independence and meant a greater need for the use of things like commodes. So equipment, there were frequent issues with the appropriateness of the equipment if it was available. Many had to wait several days for basic bariatric equipment, and equipment for pre-planned elective admissions was not set up on the ward or didn't meet participant needs. So the third finding was dissonance between dependency and need for assistance. So this was a key finding of the study, was that staff had varied knowledge about patient mobility that affected the patient's rehabilitation journey. Their assumptions were often made by staff about the actual level of ability the participants were capable of undertaking. Participants were rarely assessed in respect of their actual ability to be independently mobile or self-caring. Participants also expressed concern about risks to staff when physically moving them due to their weight, and believed that there was little negotiation between themselves and staff as to how this could be achieved so they could maintain self-determination and still be assisted. And I think this is a common scenario that we all see in clinical practice, that the patient is not listened to about how their own body moves, about how their own soft tissue moves in relation to their own body. And what we find is that the health professional continues with mobilization, with moving and handling of that person as if that person is of normal size. So there were some key findings to this study. So the first is that for participants who were admitted acutely, their mobility level prior to hospital admission was a significant feature that impacted on their length of hospital stay and their rehabilitation progress. So what is the implications for this finding? Well, we really need to develop bariatric care pathways that take into consideration a much stronger emphasis on mobility status and include comprehensive mobility assessment prior to hospital admission for elective patients and on admission for acute patients. And at our hospital, this really informed our bariatric care pathways and our equipment bundles, in that we developed pathways around mobile patients and immobile patients. And this was a really significant piece of work in this space. The second finding was that for all participants, the placement of their bed space, their bed allocation in relation to the bathrooms really impacted on their ability to mobilize and be independent, their ability to self-start and be mobile. So the implication for this is that there needs to be much more consideration by managers and patient bed coordinators about the allocation of where the patient is positioned in relation to some of the main facilities that the person will be using. So the third finding is the lack of staff knowledge and the assumptions made about participants being more incapacitated than they actually were, because this had both emotional and physical implications on the rehabilitation experiences. And this led to a dissonance between their need to feel safe and their dignified and the desire for independence. So what's the implication? Professional development needed that focuses on patient-centered rehabilitation to support quality of care and patient satisfaction. So the final study was a focus on staff education. And so this study is around attitudes and weight bias. So health professionals providing care to plus-size patients not only have to attend to the patient's specific or health needs, but they also need to address the challenges posed by their own attitudes and any weight bias towards people of larger size. And the National Institute for Health and Care Excellence in 2014 recommended that to address the issues of weight stigma, health professionals need to develop a better understanding of the experiences of plus-size people regarding their weight. So one novel approach to increase understanding of the experiences of plus size is to replicate the experience for health professionals through simulation. So the aim of this study was to assess the impact of using a simulation suit on the attitudes and perceptions of health professionals, and to understand the safety, ethics, and the effects of using simulation suits. Now, I do just want to point out that there are lots of ethical considerations about the use of simulation suits, and we acknowledge that the use of simulation suits is controversial. And at the time when we chose to undertake this research, there was a lot of authorities purchasing simulation suits and using them in clinical practice, and we decided that it was imperative we undertook some research to ensure that what we were doing was not harmful. And so I'm not going to talk now about the ethics of the suit, because that in itself is a whole presentation. So I'm going to leave the ethics of the suit and park that for now. So there were 7 health professionals who wore the simulation suit for up to 4 hours and went out into public spaces and completed several activities. These included eating in a cafe, going to the beach, and travelling between activities we did pre and post survey and interviews with the participants. So the pre-suit perceptions were framed around concerns about moving and handling injuries, physical challenges of care, and weight bias. And you can see here all the different types of comments and ideas that the participants had. So the post-activity interviews. So participants were interviewed after the activities while still wearing the suit. So despite their existing awareness, participants had not expected the extent of the physical challenges they experienced when wearing the simulation suit. They commented how their physical size affected their ability to safely and easily negotiate environments they had not previously regarded as challenging. As a result, participants had a greater awareness of space, size, visibility, and the impact the physical size of the body had on activities of daily living. So social experiences. So when wearing the simulation suit in public, participants became aware of the social stigma plus-size people experience. Some referred to feeling invisible and not being acknowledged. People talked about social interaction. Participants observed a stark change in social interactions with others. Participants reported that other people, including hospital staff, acted in ways that portrayed disapproval and judgment. People glanced sideways and stared or made no eye contact, ignored participants' attempts to interact, and in doing so devalued them as individuals. They were also talked about changed perspectives around social withdrawal. Participants reflected on insights into how the experience of social stigma could result in socially isolating behaviours. So how does this translate into practice? So when asked about whether the experience of wearing the simulation suit had influenced their own attitudes towards plus-size people, participants reported intentions to be judgmental and more empathetic needs size people. So all these important considerations for practice, both in terms of the physical layout environment, supporting patients with rehabilitation from the time of admission, and developing a trusting therapeutic relationship between health professionals and plus-size patients during care episodes. Now, I don't have time in this presentation to fully explore the practical implications from the research presented. So I hope each of you will be able to take away the most important findings for you and apply it to your practice. So thank you for your time this morning. And thank you very much for inviting me to come and talk to you today.